questions, just message me or just on your mic and give a shout out. Okay, and we'll have some discussions at the end of the talk. So these are the two guidelines, relatively new guidelines, latest guidelines on acute pancreatitis. Feel free to go and read them by yourselves. Okay, I'm sure it's available on the net and you can even download it. Okay. None of my talk will be guidelines or guidelines. You should have it as, but practical aspects are something that we're going to look at after this. Okay. So what is acute pancreatitis? Okay. It's an inflammatory condition of the pancreas that causes pancreatic injury, local injury, systemic inflammatory response syndrome, and organ failure. And substantial suffering and morbidity. In severe acute pancreatitis, the mortality can go as high as 30%. This can be quite a scary number, but most of the pancreatitis that we normally see in the ward are mild or moderate pancreatitis. On and off, we do get the severe acute pancreatitis, but that is a very challenging cases to manage. Okay. They have unexpected severe abdominal pain. It can be very distressing for the patient. Okay, they're not sure what's happening. They have severe pain that they can't tolerate. They thought, could it be a MI? Could it be a heart attack? Or it's a similar kind of emergency like a heart attack, stroke, and things like that. Okay, it is an acute thing. It is unexpected. Patient will just suddenly just get it like that. Okay. So how you diagnose? These are the basic stuff: clinical, laboratory, and imaging. Okay, you need any 2 out of 3. The clinical, classical, epigastric, radiating to the back, associated with nausea and vomiting occasionally. Okay, and one of the cornerstone of diagnosis is the serum amylase. Okay, any elevations more than 3 times upper limit normal is considered significantly elevated amylase, and that can be a diagnostic criteria for acute pancreatitis. Okay, and imaging is the other thing. Radiological evidence of pancreatitis. It's a spot-on diagnosis. Okay, you come in with abdominal pain, Hi guys, I'm back. Okay. So any 2 out of 3 diagnoses, we are good to go. Okay, that means it's etiology of acute pancreatitis. This is something that you guys have to keep in mind. Okay, I have changed place. Hopefully this is better. Okay. Let's go back here. Okay. Most common cause, biliary, biliary. Then comes in alcohol, then the others. Okay, so you guys don't need to remember so much about the others, but we'll go through about them later, right? Okay. Okay. So when a patient comes to you in ED, either you're seeing the patient in ED or you're seeing them in the ward or you're seeing them for the first time, this is the initial assessment, okay, of the patient has to follow these specific goals. Okay, we got 4 major goals, all right, on what are you trying to achieve when you make that particular assessment of the patient in the ED or in the ward. First is you're going to predict the severity, okay, you're going to determine the etiology, then comes in fluid resource and analgesia. These are the 4 main goals that you will try to achieve when you first see the patient in ED. Okay, how we go through them. Okay, first is predicting the severity. So there are tons of clinical scoring systems available. These are just a few examples of them: Apache, Bicep, Ranson, Glasgow, Embry, POP, PANC3, and every association or every country or every unit will somehow come out with their own scoring system and validate it, and then they say that theirs is slightly better than the others. Okay, but again, when you guys look at all the scoring system, it just means one thing. Okay, the importance of it is to predict which patient will have severe acute pancreatitis. When we talk about severe acute pancreatitis, we are talking about persistent organ failure. That is the key point here when you're talking about severe pancreatitis, organ failure. But uh, so all these criteria, when we look at it, when the initial scoring system or the scoring criteria shows a very high number, example, Ranson more than 3 or Apache more than 8, okay, it just means that there are higher chances for this group of patient to go into severe pancreatitis. Okay, because severe acute pancreatitis is not something that we diagnose right at the initial presentation. Okay, I'm going to tell you about that a bit later. Okay, but the scoring criteria is something that you have to use on admission to decide, or to sort of like tell yourself, hey, you know what, this guy has a higher score, so that means that he might end up having a severe acute pancreatitis. Okay, so do I need to do something about it? Yes. Okay, so if the scores are higher, then you should think whether are this group of patient fall under the higher risk group of patient, okay, where they can deteriorate very rapidly. So does that mean that they need to be in the ICU setting for a better and closer monitoring of your hemodynamics, of your other organ failure, blood results, and things like that. Okay, so that is one of the things. And of course, the higher the risk, it increases the risk of infected necrosis, organ failure, and longer hospital stay. Okay. So just one of the few, the usual one that you guys will normally use, Apache and modified Glasgow. You can use it in either ED and ICU. They got a lot of criteria involving it. I think those you can just go back and read. You can Google them and they'll come out right in front of you. Ranson is a bit more detailed, okay, but it's also a bit not so accurate on admission, because you need two scoring. One is on admission and the other one at 48 hours, okay? So that will also decide on which category the patient falls in. Bicep score is a relatively very easy scoring. Okay, you can just do by the bedside. It's nothing but age, SIRS, patient mental status, and blood urea. Okay, so you can do at the beginning of the disease. Okay, but if you ask me personally, the most important measurement, or the most important criteria that we can use, or we can decide on monitoring this thing is nothing but SIRS. Okay, so whenever you have systemic inflammatory response syndrome, either your blood pressure, tachycardia, your usual thing that you normally use for SIRS, that's what is dynamic. Okay, and you can measure it throughout the admission. Through the moment patient come into ED, you assess that. Then after you give initial resuscitation with fluid and all that, you can reassess back. So that is a bit more dynamic kind of markers, where it'll tell you, hey, look, patient is improving, or no, patient is not improving. Okay, the scoring criteria that you're going to do as a one-off in the beginning, okay, may or may not be accurate. It can be just one-off thing, and patient can deteriorate next hour, or after 5 or 6 hours patient can have another organ failure, so that part is not addressed very well in some of the scoring criteria, because most of the scoring criteria only look at on admission, and only Ranson look at on admission and at 48 hours. Okay, then based on all this scoring, we come to classification of the pancreatitis. Okay? This is not okay. Sorry. So transient organ failure is moderate pancreatitis. And when you talk about severe pancreatitis, it is persistent organ failure for more than 48 hours. That's what I mentioned earlier, that you cannot diagnose severe pancreatitis on admission. When you talk about severe pancreatitis, it can only be diagnosed at 48 hours when there is persistent organ failure. But you can predict a severe pancreatitis based on the scoring criteria. So the scoring criteria does nothing but to predict a severe acute pancreatitis, right? Clear? Was it confusing? Okay. Okay, then comes to determining etiology. Okay, it may be quite important to determine the etiology right at onset of diagnosis itself, because it may help us to decide on management or decide on further investigation that we're going to order. Okay, but as I said, most common biliary and alcohol. Okay, so even if you close your eye, patient coming with acute pancreatitis, you just say likely biliary. Okay, let me rule out biliary first. Okay, and alcohol is very easy to rule out. You just got to ask the patient and the family, does he drink alcohol, any recent history of binge drinking of alcohol? Then you get it, alcohol is the most common cause, right? And once you rule out biliary is when you will start thinking of all the other causes, okay? So if on initial presentation itself, you are not sure whether is it biliary or is it alcohol, then you got to check a bit more in terms of medication history, check whether patients are on any drugs, any family history of pancreatitis. It could be recurrent acute pancreatitis. They might have some amount of inherited genetic disease, or is it because of high triglyceridemia, or is it autoimmune pancreatitis? Check at the calcium level, and those are the things that we normally do once we have ruled out a biliary as a cause, biliary and alcohol is a cause of pancreatitis. Okay, but again, keep in mind that around 20 to 25% of the cases, the etiology will not be evident. Okay, out of them, maybe half of them, the etiology may be evident when they present for the second time or henceforth after that. Okay, sometimes when they have recurrent acute pancreatitis, then you might start diagnosing them as inherited genetic hereditary pancreatitis. Okay, so on initial presentation, up to 20%, you may not know the cause, right? But just keep in mind, one of the most important thing that I personally feel is quite significant is raised ALT. Most of the studies, or rather some of the studies have mentioned more elevated ALTs or more than 3 times upper limit normal have a 95% positive predictive value for biliary pancreatitis. Okay, but in our setting, I take it as ALT of more than 200. I'll take it as a very high positive predictive value for biliary pancreatitis. Okay. Then comes to as the most important thing, okay, or rather I would say is one of the goal of treatment of acute pancreatitis, fluid resuscitation. See, fluid therapy to prevent hypovolemia and organ hypoperfusion is a long established cornerstone. It's been on decades, and probably even a century ago they came out with this theory, and it's still true for now. Okay, it's one of the major cornerstone of initial management of acute pancreatitis. When you talk about patient coming in with acute panc, you just first thing you're gonna think about is fluid. Okay, that's the it's been established, and most people probably won't go far from it. Okay, but however, a lot of evidence basis for the fluid therapy in acute pancreatitis is relatively weak. When they look at, they don't have a specific consensus on what type of fluid do I give. Do I give normal saline? Do I give Ringer's latte? Do I give Hartmann's? Do I give colloid? Or do I give Voluven or Gela or bloods? And rate, what is the rate? Do I give 10 ml per kilo? Do I give 20 ml per kilo? How much? 3 liters, 4 liters per day? And how do I monitor them? So a lot of studies has been done. In fact, hundreds of studies has been done and published in terms of fluid resuscitation, looking at specifically fluid resuscitation alone in acute pancreatitis, but none of them can come to a specific consensus or specific guideline to say that this is what you should follow. Okay, but a lot of people have looked at hematocrit, have looked at Ringer's lactate as one of the major thing, saying that Ringer's lactate is far better than normal saline and other bloods. Okay, but the ultimate goal of fluid therapy, that why are you giving them fluid? Okay, it's mainly to reduce the complication and to reduce the SIRS. Okay, the systemic inflammatory response syndrome. So the few theoretical things behind fluid resuscitation in acute pancreatitis is when there is hypoperfusion of the pancreas. Okay, that's when pancreas will become ischemic and necrosis will set in. Okay, when the necrosis set in, that is considered a dead pancreas. Okay, because once the pancreas is necrotic, that's when all your major complications, mortality, bleeding, infection, and all that will set in. Okay, so the goal of initial fluid therapy is to, as much as possible, to reduce the risk of pancreatic hypoperfusion, hoping to prevent pancreatic ischemia and pancreatic necrosis. Okay, but some people do argue that by the time patient come in severe pancreatitis, there's already hypoperfusion, there's already ischemia of the pancreas took place. So it's also important to inform our patients, or to get patients to come to the hospital as early as possible. Because say they have pancreatitis today, by the time they just take something at home, they come in the next day. By the time they come in the next day, there's already hypoperfusion, there's already ischemia, there's already organ failure set in. Sometimes it can be too late to even reverse most of the things. Okay, so the ultimate goal of initial or early fluid resuscitation is important here. So they have all looked at two major types, if you want to break on most of the studies that they have done. They look at aggressive fluid resus and non-aggressive. Okay, this is just one of the example. Aggressive means 20 ml bolus plus 3 ml per kilo per hour. And some said you should give aggressive fluid resus if the hematocrit is low, and if the hematocrit is high, you need not necessarily give aggressive fluid resus. You can go for non-aggressive, which is 10 ml per kilo plus 1.5. Okay, but most of the data there is mixed. Okay, some data came out saying that aggressive is better than non-aggressive, and some say no, non-aggressive is better than aggressive. Some say no, it's neither better, you just got to go in between. Okay, but most of these studies are small numbers, so none of them has a significant power to tell us or to dictate us this is what we should give and not the other. So most of the, I just summarize some of the things from the aggressive, what the aggressive fluid resuscitation has shown. It has shown to increase rate of sepsis and mortality. That's something that we have to take into account. But at the same time, it significantly improves SIRS and also having patient to have an earlier clinical recovery. So even you just look at those three things tells you that, hey, it does say that improve SIRS, but again, it increases the rate of mortality, you know. So that makes us wonder that, is it good or is it not good? So the main thing you guys or need to understand is no one size fits all. Okay, so when you talk about fluid resuscitation, there's nothing like, okay, just a spinal reflex, 20 ml per kilo plus 3 ml per kilo per hour. No, it doesn't work like that, and it shouldn't work like that. Why? It's a very complex process of this whole fluid resuscitation. So what's most important is a balanced and a controlled fluid resuscitation. It should be physician directed as well as patient directed. So you got to look at patient's volume status, you got to look at patient's comorbidities, patient's hematocrit, patient's BP, patient's heart rate. So if a patient comes to you with a low BP and a tachycardia, you going to give him fluid. Let's say if it's a young patient, not much of comorbidities, you're going to go for aggressive. Okay, but at the same time, say someone in his 60s come in with a mildly low BP, at the same time his kidneys are affected, he got a cardiomegaly, you're not going to run the same aggressive fluid resus with 20 mils per kilo bolus and the high dose of fluid resuscitation, you see. So I think that is the key here, that you guys must understand. Not everybody requires a 20 mil per kilo bolus. Okay, so it should be physician directed and patient directed. And the aggressiveness of fluid resuscitation, as I mentioned earlier, is mainly to prevent the pancreatic ischemia and hoping to reduce the pancreatic necrosis that may take place later. So as we know that the chances of you having a severe necrosis or severe pancreatic ischemia is higher when you are having, or when you're going predicted to have a severe pancreatitis. Okay, so again, coming back to our scoring criteria, it's important to identify that group of patient right from beginning, okay? Because you would have already identified, look, this group of patient might develop severe pancreatitis. I must be a bit more aggressive with this group of people compared to someone who comes in just mild pancreatitis. Say, come in abdominal pain, mild is high BP, normal, not tachycardic, no SIRS, and you're not gonna. There's no necessity to load them with that much of fluid. Okay, so in a patient when they first come in predicted severe or even severe pancreatitis, try to aim for 3 to 4 liters of fluid per day, okay, for at least 24 to 48 hours, okay, because the magic number of 48 hours still stays where you are going to make a final diagnosis of severe pancreatitis, moderate or mild pancreatitis, and decide the patient's further management from then onwards, okay. And ringer lactate, if you have it, is much better, okay. We have Hartmann's, you can use Hartmann's. Avoid Voluven. There are some studies that has been done to say that Voluven, for some reason, is cause a bit more detrimental effect in acute pancreatitis. Okay, tend to use more colloids if the hematocrit or the albumin is very low, and monitor the patient's urine output, hematocrit, urea, CVP. Again, as I said, when you already predicted someone to have severe pancreatitis, the patient should either be in ICU setting or a high dependency ward setting. Okay, so more closer monitoring is definitely important. IVC scan, then decide on boluses of fluid, or whether looking at the urine output is low, I'm going to give him more boluses. So all that can be directed as patient directed or physician directed. Okay. Next, come to analgesia. Okay, I mean, the main reason they come to your ED or your ward is because of pain. Without the pain, probably they won't even be in ED. So that's something that we have to address very specifically and very early. Okay, opioids are proven to be quite effective. Okay, why? Also because they also work as a smooth muscle relaxant, and they relax the sphincter of Oddi or your biliary and a pancreatic duct sphincter. And in terms, reduces your obstruction or pressure of your pancreas. Okay, maybe I'll just show you one diagram later to show how this whole pancreatitis thing works place. Maybe after this slide. So some studies has also used NSAIDs, use diclofenac, Celebrex. You can even use acetaminophen. Okay, but when the patient come in with severe pain, PCA can be very helpful when it's available. Okay, try to order or get PCA involved at a very early stage rather than a later stage. Okay, because at the end, patient's comfort is what comes in. I mean, you don't want a patient to be there in pain. When the patient is in pain, his pulse rate will go up. Then you'll be confused whether the patient in pain, or is it because his SIRS is not improving despite your fluid, you know. So always make sure his analgesics are well taken care of. Okay, then comes in as others. Okay, nutrition. Early oral feeding is and so there is no reason to keep them fasted. Okay, I know last time, the olden days, uh, most of the literature before said that no, acute pancreatitis, fast them, keep the pancreas at rest, keep the gut at rest. It doesn't work like that anymore. Okay, we should aim to try and give them early oral feeding. Okay, within 24 hours, as much as patient can tolerate it. So again, that's the key here, is as tolerated. If the pain is better, patient say, I want to drink, let them drink, no problem. But the moment patient complains of pain as patient takes liquid, then you just got to ask them to slow back a little bit. Okay, or say, I can tolerate soft diet, but solid diet I get a bit of pain. Okay, then take a step back, stay on soft diet for a while, see as how you can tolerate it. And again, it goes to patient directed. If patient feels that patient can drink or patient can eat, then you let them eat. Okay, it's also important to advocate a low-fat diet at the initial phases of recovery of acute pancreatitis. Okay, talk about that also later. Okay, so Yeah, so this is on day 2 of admission, that when we're talking about 48 hours of admission, right? So these are the things that you're gonna assess to decide on what are you going to do with the patient after this, okay? Are you gonna send him home? Are you going to keep him in your ward? Are you gonna send him to ICU? Or are you gonna do further imaging and things like that, okay? So 5 important things. Organ failure. If at the end of day 2 at 48 hours, there's no organ failure, patient can tolerate solid diet, no evidence of SIRS ongoing, abdominal pain to minimal as the most, and very, very little or nil opioid usage, means that patient is good to go back home. Okay. If any of these things are present, say there is organ failure, uh, then you might want to think that, okay, this is definitely a severe pancreatitis. Uh, are we supposed to anticipate further deterioration in his clinical outcome? Is he going to have further deterioration of his organ failure? Is his kidneys are going to go down further? Is his lungs are going to go down further? So all that needs to be adequately managed, monitored, and treated as the time comes. If the patient can't take a solid diet, that means the pancreas is still very, very inflamed, okay, and you wouldn't want to add on anything to a inflamed pancreas, okay. SIRS, any evidence of SIRS, low BP, tachycardia, and all that, all just means that there is active inflammation going on in your pancreas, okay. So when there's active inflammation going on in your pancreas, also means that there is potential for further deterioration in clinical scenario. Patient can deteriorate further. Patient go into ARDS, patient can go into abdominal compartment syndrome, patient can go into sepsis, infection, and things like that, okay. Abdominal pain, also in relation to pancreatic ischemia and pancreatic inflammation, okay. And opioid usage also means that his pain is not very well controlled yet. So let me show you, sorry, let me show you something. Okay, can you all see my whiteboard? Okay, so that's the pancreas, and you have your pancreatic duct here, okay, and your bile duct will come like that, okay. So that's your liver, your intrahepatic duct, okay, that's your gallbladder, okay. So in let's take an example of pancreatitis, in a, say example, biliary pancreatitis. So what happened is when there's a small little stone there, okay, when the stone is trying to pass out right down here at your sphincter foci, at your pancreatic orifice, at your ampulla, okay, when it's a very tiny stone, very, very tiny stone, it just passes out without causing any problem, okay. When it's slightly bigger, when it's trying to pass out, that's when it'll try to block the pancreatic duct. So your pancreatitis happens when there is blockage at the pancreatic duct orifice. So when there is a obstruction or blockage at the pancreatic duct, it causes significant ductal hypertension, okay, ductal hypertension in your pancreas, right? So because there is a ductal hypertension, your pressure within the pancreas builds up, okay, and then there will be some evidence of ischemia and severe inflammation all will be going on and that pancreas, okay. So assume that that particular stone, when it's trying to come out, okay, and if it's impacted, that this is that's a problem that will cause. If the stone eventually passes out, okay, how the stone will passes out, either just by time, okay, or when the patient come in when with the severe pain, we give them opioids. So what does opioids do? It relaxes your sphincter. When the sphincter relaxes, the whatever stone is trying to pass out which couldn't pass will eventually just drop down. When the stone comes out of here, there will be good drainage of your pancreatic juice, okay, hoping for the ductal hypertension to resolve, and eventually the pancreas will not get further damage. So whatever damage has happened to the pancreas will be limited to that one, just say particular time, say example a few hours, okay. But If there's a continuous obstruction at the pancreatic duct, there will be continuous damage or inflammation going on in your pancreas. That's when your pancreas will keep on getting inflamed and damaged and all that. Okay. And this is important to recognize as a complication of pancreatic necrosis. All right. So now let's go back to my slides. Okay. Okay. So now, now let's talk about complications. Okay. What can happen in pancreatitis? So most of the complication will happen in the local region. If you have interstitial pancreatitis, then you can develop acute peripancreatic fluid collection and eventually will become a pseudocyst. So when it's less than 4 weeks, we call it acute peripancreatic fluid collection. And after 4 weeks, when the acute peripancreatic fluid collection has formed a nice collection, it's called a pseudocyst. Okay. And in case of necrotizing pancreatitis, the patient will end up developing acute necrotic collection, which will be walled off pancreatic necrosis eventually. Okay. We also possibly will be concerned about PD disruption, splenic vein thrombosis, pseudoaneurysm. All these are complications that we need to keep in mind and look out for. And keeping in mind that most of the complication happens in moderate or severe acute pancreatitis. Very, very few patients with mild pancreatitis develop any of these complications. Okay. But that being said, not that we're going to ignore people who are coming in with a mild pancreatitis, it's just that we're going to follow them up. But your index of suspicion or the care that you're going to give someone who had acute severe pancreatitis will be far more greater, and you're going to monitor them more closely compared to someone who had just mild pancreatitis. Okay. Then when you talk about systemic complication, then basically we're talking about exacerbation of pre-existing comorbids or even deterioration of their lung, kidneys, liver, heart, GI tract, etc., etc. Okay. So management of complications are definitely patient-centric. Okay. We manage the complication when patient has symptoms related to that. Okay. If there is a pseudocyst and if the patient has no symptoms, no symptoms, say no abdominal pain, no early satiety, no fever, no pain, we probably not going to do anything about the pseudocyst. Okay. But if there is something need to be done, if patient has any symptoms, then the minimally invasive methods have far better prognosis than a more invasive methods of managing the complication. We are talking about minimally invasive mean endoscopic versus percutaneous drainage versus surgery. Okay. Surgery has shown to have very, very high rate of mortality to a point that it is unacceptable to have surgery done in this group of patients. But again, sometimes we can't really avoid them, especially when they are very, very sick. We don't have much option, and surgery can be attempted. Okay. But even if any interventions need to be done, say example, pseudocyst drainage or walled off pancreatic necrosis drainage, it's best to delay the intervention for 4 weeks if possible. If the patient can tolerate it, we should delay it for 4 weeks. Why? Because we are hoping for the wall of the pseudocyst or the walled off pancreatic necrosis to be well mature and well formed before we do any endoscopic stenting or drainage through the stomach. Okay. So even if you want to drain the pseudocyst or want, endoscopic approach has shown to have a far better outcome than surgery. Okay. But if the patient is very ill and very sick, we should consider percutaneous drainage. Okay. And surgery, as I said, is a very high, unacceptably high rate of mortality. So if at all you guys want to remember anything, okay, these are the key points to remember from what I have explained earlier. So the early management is one of the most important key factor in management of acute pancreatitis. Okay, identifying the etiology. Yes, it is important to know what causes it. Okay, but if it's not identified on initial presentation, don't worry so much about it. Manage the acute pancreatitis part first, and we can always consider a further workup later on. Okay. Balanced and controlled fluid resuscitation. Keep this in mind. No one size fit all. Not everybody gets your massive boluses and high dose of fluids. Okay. Go by the patient, go by the predicted severity, go by the clinical scoring system, and go by your judgment, okay, as a physician. Uh, and also look at other modalities like your urea, your hematocrit, your blood pressure, CBP, urine output, and use all those parameters to guide and judge how much fluid you're going to give them. Okay. Analgesia, mixed modality, say opioids plus PCM plus minus NSAIDs, diclofenac, all have shown equal amount of efficacy. Okay. But opioids, I personally feel still a mainstay. Okay, try to engage our PCA as early as possible. Okay, and encourage early ambulation and early oral intake. Okay, that the early oral intake is one of the important aspect also for feeding and nutritional aspect in terms of acute pancreatitis. Okay, and management of complications, minimally invasive, depending on patient symptom and nutritional support. Okay. So before I go to the cases, any of you all got any questions? You want to ask questions first? Anybody? Anything not clear? No?
Dr. Raj, I think we can proceed to the cases first, and
Okay.
maybe they might have
All right.
questions.
Okay, these are just basic, simple cases just for discussion purpose. Okay. So case number 1, 42 years old lady, teetotaler, coming with severe abdominal pain, epigastric radiating to back, say at 10 a.m. She had nausea and vomiting at 2, presented to ED at 1 p.m. with the same pain. Okay. So in your ED, she mainly came in just for the pain. Blood pressure, pulse rate, temperature, all good. Abdomen, just mild tenderness, epigastric, no guarding, no jaundice, lungs clear, amylase 2004. Okay. Any other tests you want to do? Yes, you might want to know you already diagnosed her as acute pancreatitis. She had the typical pain. She had elevated amylase. It's acute pancreatitis. But the next step is you're going to find out the etiology. So you're going to do some basic blood tests, look at the LFT, look at the renal function, CRP, hematocrit, and do your scoring criteria, okay? And decide whether this patient has likely possibility of having a biliary pancreatitis, okay? Still high on the list, again, because she's a teetotaler. So alcohol may not be as your possible etiology. So we will still think biliary as one of the most commonest cause of acute pancreatitis. Okay, and looking at the numbers, everything looks good. No organ failure. HB is good. Hematocrit is good. Okay, what do you do next? You might want to consider other differential diagnoses as well, like other gallstone disease, cholecystitis, appendicitis, perforated gastric ulcer, peptic ulcer disease. All those will be your differential diagnosis when the patient come in with severe pain. So you would have also done all those other investigations, say a baseline ECG, if she has any other comorbidities like diabetes or something. You also might want to rule out ischemic heart disease. X-ray, if the abdomen was severely guarded. You also might want to rule out a perforated ulcer, or it could be a simple peptic ulcer disease. So all that also need to be considered as part of your differential diagnosis. Okay, then you're going to hydrate her. You're not going to give her massive boluses. You're going to hydrate her according to her BP and pulse rate. You're going to give her maybe non-aggressive hydration. You're going to give her some analgesics. Get an ultrasound for her. Ultrasound showed gallstones, CBD and IHD not dilated, liver normal, pancreas not visualized, the common things we see in the ultrasound report. Okay. So coming back to a bicep score, it's 0. Okay. So it means that the chances of her having severe pancreatitis is relatively very low. Okay. What you're going to do, you're going to admit in a general medical or gastro ward. Okay. You're not going to send this patient to ICU or HCW, not at this initial setup. Okay. But bear in mind that people with even mild pancreatitis on admission, they may deteriorate while they are in the ward. Okay. So it's important to keep a very close eye on them for at least the first 48 hours. You're going to continue the hydration and analgesics. Okay. Once the patient has abdominal pain is better, you're going to allow her to start taking liquids and then soft diet and solid diet as how she can tolerate it. Okay. So next, what you're going to do, you're going to keep her for two days. Okay. For 48 hours, you're going to monitor blood pressure and pulse rate. You're going to monitor her temperature, monitor her pain score, see how much she can tolerate. Okay. So once all this okay, at the end of day 2 at 48 hours, you're going to assess again for any organ failure and whether the patient can take any food, any stress, any pain, any opioid use. None of that are present. Blood's LFT has pretty much come back to normal. Okay. She had a bilirubin of 41 earlier and ALT 250, and which is pretty much as normalized, right? So final impression for her is most likely a mild acute biliary pancreatitis, right? Agreed? Any other differential you guys might want to consider at this point? So by the end of day 2, you probably would have already ruled out all the other causes, like I mentioned, perforated ulcer, cardiac ischemia, appendicitis, on all those would have been ruled out. Okay. So next, what you're going to do? So in biliary pancreatitis, 4 things can happen. Let me draw for you all again. Okay. So that's your CBD. That's your PD, and that's your pancreas. Okay. So once your stone is here, if it falls out, that means, as I said, either with your opioid or it's because it's a small stone, it somehow passes out. Okay. Then patient will have pain free. LFT will improve. Okay. So when pain gets better, when LFT improves, means most likely the stone would have passed out. Okay. But if the stone is still there, right at the ampulla, causing obstruction, patient's pain will increase. Okay. And LFT also will worsen, because eventually when the stone blocks off here, the system gets dilated, patient gets jaundice, and he may also get cholangitis. Okay. So this is one thing can happen if the stone is stuck there. All right. So the other possibility is the stone was, say there could be a big stone. Okay. It's a modern amount of stone. All right. So one small piece of it would have come out and then blocked off and eventually passed out and caused the pancreatitis. But there can still be 1 or 2 small stone fragments stay within the CBD. And these stones will be a floating stone and it will not cause obstruction. So in this case, pain will still get better. Okay. But LFT may not improve significantly in terms of ALT. Bilirubin might come down, okay, because this particular small stone is not causing an obstruction. Your ducts are not dilated. Okay, and no jaundice. But there can still be a stone within your CBD, all right? So this is one possibility. And of course, the other possibility is even the stone would have passed out, patient has significant necrosis going on in the pancreas. Okay. In this case, pain will be persistent or higher, but LFT will get better. Because the stone would have passed, no jaundice, LFT will be improved. But because the damage that has been caused to the pancreas, that will cause significant amount of pain because of the necrosis which is starting to take place within the pancreas. Okay, so coming back, sorry. So coming back, 4 things can happen. If the stone passed out, pain-free, LFT normalized. Okay, you can always take an ALT reduction as by more than 50% in 48 hours can be a good predictive marker to say that stone has passed out. Okay, but these are all very subjective measures. Stone impacted at the ampulla, as I draw earlier, it causes persistent pain, worsening LFT and jaundice, plus minus cholangitis, because the stone now is blocking both the CBD and PD. And when it blocks the CBD, your biliary ducts get dilated, you get jaundice, and you may get cholangitis. So, and the third one is when the stone remain in the CBD. Pain improves slightly, but LFT is still impaired. Okay. And in this case, the stone is not causing obstruction. The patient may not have jaundice or may not have cholangitis. And of course, the other one that can happen is necrosis. Persistent pain. LFT would have improved because the stone would have come out, but because of the persistent inflammation or ischemia that has taken place onto the pancreas, your pancreas becomes necrosed. So in this group of patient, they can have very high CRP, plus minus fever, and all these things can happen. So in all these 4 scenarios, okay, most of the time you can diagnose them clinically. You can have a picture in your mind clinically at the end of day 2 to decide whether stone has gone out, stone is still there, or patient is having necrosis. Okay, but the next step is actually to detect the presence or to decide whether there is presence of stone in a CBD in a more objective manner rather than a subjective assessment like earlier. Okay, so we have 2 modalities of treatment or of investigation. One is MRCP and EUS. Okay, basically to look at stone in the CBD. If there is a presence of stone within the CBD and which is undiagnosed and you discharge them back home, there is a high chances of patient coming back with recurrent acute pancreatitis because that particular small stone might still try to come out, or it might cause blockage in the bile duct, it might cause cholangitis, or it might cause another pancreatitis. Okay, so it's a good practice, or it's good for the patient. It's important to make sure that the CBD is clear before we discharge such patients. Okay, one of the way is getting an MRCP, and of course the other way is endoscopic ultrasound. Endoscopic ultrasound is a far higher sensitivity for CBD stone compared to MRCP. Okay, because EUS can even pick up a stone which is less than 5 millimeter in size. MRCP is not that good for a stone which is less than 5 millimeter. But again, MRCP is good enough if it is available. But I suppose in our setting, EUS is more readily available than MRCP. Okay, so our practice has always been an EUS before discharge in a patient with mild acute biliary pancreatitis. Got to make sure that the stone is there or no stone in the CBD. If there is a stone present in the CBD, patient will need ERCP to clear the stone. Okay, on the same admission or the same sitting. If there is no stone within the CBD, patient will need surgical referral for lap cholecystectomy. Ideally, the cholecystectomy should be done as inpatient, but because of our logistics and our waiting period and all that, that hardly takes place. Okay, but as much as possible, the problem happens when you don't take out the gallbladder early, or when you don't take out the stone in the CBD early. There are high chances that they can have recurrent acute pancreatitis and they can keep coming back again and again with pain, right? Okay, so the main reason to get them for lap chole early and also to clear the CBD is to prevent a further recurrence. Okay, so let's go to case number 2, right? 62-year-old. Am I running out of time or are you guys okay? Okay, I'll just go quickly on this one then. Okay, 62-year-old man, heavy alcohol consumption, present with severe abdominal pain following an episode of binge drinking. Again, when you look at etiology, patient comes in after alcohol drinking, put your alcohol as top most cause for the acute pancreatitis. So at ED, his abdomen was tender, he had guarding, he had absent bowel sound, BP low, his pulse rate high, low grade temperature. So all those are pointing towards a systemic inflammatory response syndrome ongoing. Okay, if not, maybe 1 or 2 organ failure already, just based on your initial examination alone. Absent bowel sounds likely means that there could be ileus going on. Okay, so you do the usual blood test, check your amylase high. You would also want to do your abdominal x-ray to make sure it's not a perforated gastric ulcer, right, or obstructed colon or obstructed bowel. Okay, and you do your regular blood test, use creatinine to look for any renal impairment or renal failure, glucose, CRP. These are the usual blood tests that you do. And of course, you're going to come up with your uh, clinical scoring criteria to assess the severity or to predict the severity of the acute pancreatitis. Okay, so why is important? Use the clinical scoring system. It predicts the severity, because on admission you can only diagnose as predicted severe acute pancreatitis. As I said, the diagnosis of severe acute pancreatitis is made only at 48 hours of admission. Then you're going to come back and look back at etiology, likely alcohol related, but given the history. But again, you might want to also rule out, do an ultrasound later once the patient is more stable. Just make sure that there's no concomitant gallstone as well. But looking at a LFT may not suggest a biliary pancreatitis. As I said, AST higher than ALT could predict a alcoholic hepatitis rather than biliary pancreatitis. Okay, then go back to fluids. So in this case, patient has low BP, patient is in shock, he's predicted to have a severe acute pancreatitis. You might want to go aggressive on him. Okay, you might want to run more fluid, you want to give the bolus, you want to make sure the BP, the hypoperfusion, if it's not fully set in, you might want to reverse that, give him good amount of fluid, check his IVC, check his urine output, look at his urea. Okay, you're going to give him aggressive fluids. It's important in the first 24 to 48 hours. Okay, analgesic, again, morphine, fentanyl, anything short acting is the best initial analgesic. Okay, go for morphine or go for fentanyl first, and then decide on PCA and see how the patient can handle it. Okay, then you have already decided or you have already predicted that this patient may have severe acute pancreatitis. Okay, so you might want to refer them to ICU for a better fluid resuscitation, better fluid management, better monitoring. You want to make sure that the hemodynamic parameters, urine output, urea, hematocrit are all being monitored more regularly. Okay, and the best place is obviously in ICU. Okay, and while he's in ICU, you're going to keep him fasted because he's severe. You're going to reassess his analgesics, make sure his pain's very well taken care. And then at 48 hours, you're going to repeat back his bloods. You're going to reassess for his any organ failure. You're going to look back at his cells, whether there's any improvement in cells compared to when he first came in. Did he respond to your fluid therapy? Did he respond to your initial management? And all that has to be assessed at 48 hours. Okay, if any evidence of persistent organ failure still remain at 48 hours, then you get your diagnosis of severe acute pancreatitis. Say his renal function improved, his blood pressure all has improved significantly with the fluid resuscitation alone, then at 48 hours you would probably diagnose him as a moderate acute pancreatitis. Okay, so in this case, we came up with a diagnosis of severe acute pain, likely secondary to alcohol. Why likely? Based on history, that's all what you get. Okay, you have not done a ultrasound and further to reassess. Based on initial workup, it sounds more like a alcohol. So we'll probably stick to that as for now. All right. Then nutrition, okay, is also an important part. Enteral feeding is way better, and you're going to decide to allow him orally as early as possible. Okay, if the patient is intubated and all that, that's the second question. But again, if the patient is intubated, you're going to start them on Riles tube feeding. All right, if the patient can tolerate orally, you're going to allow them oral feeding. Start with clear fluids, nourishing fluids, soft diet, and go for solid diet, entirely depending on patient's clinical condition and also how much patient can tolerate. If the patient is intubated or very ill, consider nasogastric tube feeding as early as possible. There's not much of a role for TPN in acute pancreatitis in this setting yet. Okay, TPN is only and only if patient cannot tolerate oral or nasogastric feeding. If there is persistent ileus, bowels are not moving, there is a complete failure of the intestine, then TPN can be an option. Okay, but if any signs of GOO or patient cannot tolerate a nasogastric tube, then you should also consider a nasojejunal tube. What can happen is in acute pancreatitis, especially involving the head of pancreas, there can be severe inflammations happening around the pancreas and around the second part of the duodenum. There can be fluid collection, there can be edema, all that can compress the duodenum and may cause the patient to have signs of GOO. So that's also something to keep in mind. Then come back to antibiotics. Keep in mind, no role for routine antibiotics in acute pancreatitis. Okay, the only times that we give antibiotics in initial setting is if you suspect patient have cholangitis. All right, when for biliary pancreatitis, if the jaundice persistent, the patient has fever on admission itself with jaundice, then cholangitis is one differential. Then there is a role for antibiotics. Otherwise, pancreatitis per se is an inflammatory process alone, okay, and may not require antibiotics at initial setup, okay. But if infected pancreatic necrosis is suspected, which usually sets in after day 5 to day 7, then the only antibiotic they're going to empirically start them on is either carbapenem or piptazole, okay. Antifungals will reserve it towards very, very, very later in stage and when patients very ill and not responding to regular antibiotics, okay. And US guided or percutaneous guided aspiration of the pancreatic fluid collection can be done to send for CNS to guide which antibiotics you might want to give patient, right? So initial setting, most of the peripancreatic fluid collection are sterile, all right, okay, unless the infection will only set in much later, usually a week later after the necrosis and all that is set in. So one of the good markers, CRP at day 3 of admission of more than 150 can indicate evidence or presence of pancreatic necrosis. Okay, procalcitonin is the other thing you might want to use to identify whether the pancreatic necrosis is infected or not. Then go for imaging. Ultrasound is only good to look for gallbladder stone and dilated duct. Okay, ultrasound not going to tell you much about the pancreas, not going to tell you much of your pancreatic necrosis, and not going to tell you much about what's going on around and around the pancreas and in the abdomen. Okay, but it's a good initial imaging to get done in acute pancreatitis. Okay, but in a setting of severe pancreatitis, ultrasound may not have much role initially. Okay, then CT or MR is the next choice to detect or to identify pancreatic necrosis, and usually it sets in only after day 4 or day 5. Okay, again, no point getting a CT or MRCP done on day 1 or day 2 of admission. It's not going to tell you much. Okay, so by the end of day 2, you will roughly have a picture in your mind whether this patient is having necrosis or is he predicted to have necrosis of the pancreas, depending on the persistent pain, CRP level which is high. All those are your predictive markers. I'm going to look into all that to decide, hey, looks like this guy is having pancreatic necrosis. Okay, he may need a CT to assess the pancreas, but I'm not going to do it now. Let's wait until day 5 to day 7 to get a CT. Okay, and the repeat imaging will only be guided by patient's response to therapy and presence of any symptoms or sign, or prior to planning any intervention. Okay, there's no point repeating ultrasound every week or every 2 weeks, or repeating CT every 2 weeks to assess the peripancreatic collection of pancreatic fluid. Okay, so if the patient has any symptoms, we'll go by that. If patient has suddenly come back with fever and worsening abdominal pain, you might want to CT them again, see whether the pancreatic fluid collection now is infected, or is it getting, is it getting bigger? Or if the patient present with any bleeding, then you might be worried about pseudoaneurysmal bleed or any variceal bleed because of the splenic vein thrombosis. Then the repeat imaging will be based on patient's signs and symptoms as patient present. Okay. So come back to this patient during ICU stay, required an IV support, required dialysis, transferred out of ICU on day 9, renal function improving, patient on nasal no fever. He was started on tazocine for suspected necrosis. Okay, so on day 17 of hospital admission, patient well, creatinine normalized, tolerating orally but minimally, complain of early satiety occasionally, no fever. Okay, so he's relatively well, but he's just recovering from a severe acute pancreatitis. Okay, and you know, he also had a possible infected necrosis. He had a necrotizing pancreatitis and possible infected necrosis, which he responded very well to antibiotics. So no intervention needed during that initial admission. But these are the group of patients that you might want to follow up closely too. Okay, so on day 17, he's well. You said you can go home, allow discharge. But you're going to make sure that you're going to ask him to stop drinking. But whether he stops drinking or not, that's entirely up to him. But our responsibility to still tell that to the patient. Okay, so you're going to see them back in 2 weeks in clinic. Okay, you're going to assess back the symptoms. Okay, whether the patient got any new onset of abdominal pain, any fever, any early satiety. If any of these are present, then he may require drainage for the walled-off pancreatic necrosis. Okay, then you might want to order another CT to assess how big is it, to decide the extent of the walled-off pancreatic necrosis before you plan for your further endoscopic intervention. Okay, and management of the complication when you see him in clinic, it all depends on patient symptom. Okay, so if patient is completely well, has start gaining weight, started eating well, no abdominal pain, completely well, you're not going to do much. You're just going to follow them clinically. Okay, there may not even be a role to keep repeating CT scan for such patient, more so when they don't have symptoms. But unless if you are worried of some other complications, say pseudoaneurysm or things like that, then it may be worthwhile to get a CT angio at the end of 4 to 6 weeks. Okay, and the other thing you're going to monitor them is exocrine and endocrine insufficiency, also depending on how much of the pancreatic tissue was dead or involved. Okay, and if there's any steatorrhea, patient might need creon or insulin if there is any evidence of diabetes. Okay, so coming back to the same key points, the same thing, same slide as earlier. If at all anything you guys want to remember, just remember this. Okay, yeah, I'm done. Any questions?
Thank you very much, Dr. Raj, for the very comprehensive talk on pancreatitis. I think there were some questions.
Sorry, your time also.
No, no worries. I think everyone has learned much. So there are some questions in the chat box, which I will just read out. I think some of it maybe you answered during your case scenarios really, but just for the benefit of everyone. So number one, is there any role of antibiotics in the management of pancreatitis?
Okay. Yes, I think I mentioned that earlier in my talk. No role of antibiotics in acute pancreatitis. Okay, there are only very few indications where we start antibiotics. Okay, when the patient come in the initial setting, cholangitis is the only only indication for antibiotics in acute pancreatitis. But of course, if the patient have concurrent pneumonia or other illnesses that requires antibiotics, that will be for entire different indication by itself. But as far as acute pancreatitis, the only indication on initial presentation is cholangitis and infected pancreatic necrosis on day 5 onwards. Okay, so usually that only sets in after day 5 to day 7. So any low-grade fever, patient come in with low-grade fever, no evidence to suggest cholangitis, there's no role for antibiotic, because as we know, SIRS also can have slight elevation in temperature. It's all part and parcel of your inflammatory process of your pancreas. But again, when we talk about the choice of antibiotic here, if you're suspecting, if you're giving the antibiotic for cholangitis, then it is your ceftriaxone, okay? But if you're giving your antibiotics for infected necrosis, then it has to be a carbapenem or a tazocin. Okay, no point starting ceftriaxone at day 5 or day 7 and things like that. Again, there's no role of starting tazocin on day 1 of admission. If you're suspecting cholangitis, it should be the usual antibiotic for gram-negative, which is your ceftriaxone. Okay. So hematocrit, yes, it's a very good predictor for fluid resource plan. Okay, even in your Ranson criteria and all that, you have your at 48 hours, 0 and 48 hours, hematocrit is one of the marker. It's a very good marker, but again, like I mentioned earlier, a lot of data are not very clear about the specific endpoint of this fluid resuscitation. Okay, always go by the patient. Okay, patient's response. Hematocrit is just one of your indicator that you're going to look at. You're going to look at your urine output, you're going to look at your CVP, you're going to look at urea, blood pressure, pulse rate, and everything. Okay, so next, fluid resource part is more fluid. Sorry, I didn't. So if the hematocrit is low, then it's more fluid. What did I write earlier? Okay. So anyway, it is if the low hematocrit, then you go for aggressive hydration. Okay. And need to do COVID swab for what again? Who's Jekong?
I think he meant that. I think he meant that any patient that's coming in before admission will need a COVID swab.
Oh yeah, I mean that's standard practice already right now for all our medical patients. So you're gonna swab them in ED, but before our procedures, we'll always request PCR at this point. Okay, we never used to request them before, but now of course during the COVID, yes. Then what are the other questions? When is the best timing for CT scan to look for complication? Again, the best timing, it depends on patient's symptoms and signs. If patient's got no symptoms, nothing to suggest any further deterioration, again, you might not even want to do a CT. Okay. But if the patient presented with severe pancreatitis initially, okay, you might want to follow up later on. Again, it all depends on patient symptom. If the patient if the patient is sorry, got distracted. Yeah. Okay. If the patient has no symptoms and patient recovered well after the severe pancreatitis, when you see them in clinic, patient has no symptoms at all right? Okay, there might not even be a need to do a CT scan, because even if there is anything that even if you find a small pseudocyst in a CT scan, because patient is asymptomatic, we might not even want to do anything. But there are a few other things that sometimes we might want to look at as a post pancreatitis sequelae, which is pancreatic duct disruption. Okay, it is also important to know to assess the degree of pancreas that has been dead or degree of pancreas that has been affected because of the pancreatitis. So MRCP is a good option then, right? Okay, but the timing, it varies and it depends on patient. If the patient presents to you before the 4 weeks with symptoms of severe pain, fever, you might want to do the CT earlier to decide and see what's going on. Okay, and yeah, so uh, no, I think it's more of yeah. Actually, you are right. If the hematocrit, that's true though. Let me go back to my slide. See what did I write. Hmm. Yeah, you might be right though. Maybe I'm not sure that I wrote that wrongly. Okay, let me clarify on that to you guys. Okay, but you may be right that yeah, hematocrit high means more aggressive hydration. Okay. Anyone else? Any other questions? Let me see.
Dr. Raj, I have a question. You mentioned that all patients with acute pancreatitis should have EUS before discharge. If you're thinking of a biliary
Preferably,
ileum.
yes. If
So,
if they've been referred, I mean, most of the patients should be referred to gastro. Okay, all pancreatitis should be referred to gastro, but that has been our practice now to US them before we discharge them. Okay, if sometimes when our timings are too tight, then we will somehow arrange a early US for them before we refer them to surgical for lap cholecystectomy. But preferably, just to smoothen things out, patient comes in day 0, mild pancreatitis. By day 2, you decide it's mild pancreatitis, you want to discharge. Day 3, get a US, no stone, you discharge them. Okay. But now with all the COVID, you need PCR and things like that. So somehow even our US can get delayed by a few days.
so in that sense, ultrasound HPS is not exactly mandatory.
Yeah, it's not beneficial, but it's good to identify. As I said, we can't do an EUS and the initial setting on presentation itself. In that sense, ultrasound is still an important thing to get it done. One thing, it'll tell us whether there are stones in the gallbladder or whether there are any dilated ducts. Okay, if there are stones in the gallbladder, as I said, the positive predictive value for a biliary pancreatitis is significantly higher again. So always ultrasound first, then KIV US before discharge.
Say if a patient comes in at maybe day 5 of symptoms, somehow had mild and then he got worse. Should we go straight for CT?
Yes, if let's say patient can clearly tell you, oh, my initial pain was 5 days ago. Okay, so then you're not sure, because if you take a serum amylase for these people, it might be back to normal already. Okay, because it's already day 5. Then there's another test called lipase. Okay, serum lipase, which usually lasts a bit more longer in the blood, and also urinary lipase. That lasts for up to 7 days. Okay, so you can also diagnose them with acute pancreatitis based on serum lipase. Then if they present to you with worsening pain on day 5 or day 6 specifically, they can tell you, then I think CT is a far better imaging modality, because it can look at a lot of other things, including necrosis, including pseudoaneurysm, complications, and other peripancreatic fluid collection. But our radiologist will probably grant you an ultrasound first before granting you the CT. So, so eventually you'll need a CT. Yeah, eventually you'll definitely need a CT.
You mentioned that amylase might be normal after a few days.
Yes.
Is there a role for using amylase to monitor resolution?
No, definitely no role of checking. So the amylase is only a stat dose of amylase where you take on presentation. Okay, there is no role of checking back amylase again the next day to see that, oh, amylase level is coming down, because that doesn't mean anything. That doesn't mean that patient is getting better, doesn't mean that the pancreatitis is not happening, doesn't mean that it's not acute pancreatitis. Okay. So once you have already diagnosed with one single result of amylase, don't repeat it again, unless patient has similar pain again. Say pain on day 0, you do amylase is 2000, then pain completely gets better, and then say day 5 or day 6, patient has another pain, similar pain, then it's worthwhile to check amylase again to diagnose recurrent acute pancreatitis, because she had one pain and she had another one acutely, right? So it is a recurrent acute pancreatitis, but no role to check amylase to monitor the progression of the disease.
All right. Any other questions from the floor? Last call. If not, I have one last question, Dr. Raj.
Yeah.
DVT prophylaxis in such patients.
Okay. In a mild pancreatitis, you encourage early ambulation. They don't need. But in severe pancreatitis, when they end up in ICU, yes, DVT prophylaxis is necessary and is important. But you also, there are few case reports to say that there are also cases of pulmonary embolism in severe pancreatitis and all that. Okay. But your DVT prophylaxis will go more towards the ill and severe patient. The moment they go to ICU and HCW, they will be intubated. You will end up giving them DVT prophylaxis anyway. But for the mild acute pancreatitis, they don't need a DVT prophylaxis, because by right, you should encourage early ambulation. By day 2 or day 3, they should be able to get up and go back. But the severe pancreatitis is something that you definitely might want to give as a DVT prophylaxis for them. Okay, or some of them may even end up developing acute portal vein or splenic vein thrombosis. Okay, and they might require anticoagulation, Clexane, and things like that as well. But of course, keep in mind that splenic vein thrombosis increases the risk of pseudoaneurysm and increases the risk of bleeding. Okay, you got to look at the risk and benefit of starting anticoagulation in that group of people.
Okay, thank you very much, Dr. Raj, for spending 1.5 hours with us, teaching us, refreshing us on acute pancreatitis. If there are any other questions, he will be happy to take questions when you meet him.
You can message me anytime.
Yeah. Okay, so I'll end this session shortly. Thank you everyone for joining. Quite very good response, full house today. We will look at increasing our capacity for future sessions. I will put up the picture shortly, QR code to scan for everyone to record their attendance. Right, so thank you everyone. Thanks, Dr. Raj.
All right, thanks. Cheers, guys. Have a good day.